Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today we have Dr. Douglas Sborov, who is Associate Professor of Medicine at the University of Utah. He leads the myeloma and the plasma cell dyscrasia program there, and he's going to talk to us about some of the updates on Carvykti in the early relapse setting in multiple myeloma. Welcome, Doug.
Thanks for having me. Really happy to be here.
Okay, Doug. So we saw some updates at the International Myeloma Society meeting held in Rio recently. So we're just going to, talk through some of these. So for our audience, can you first just give them a quick primer on what the CARTITUDE-4 trial design was, and before we launch into the discussion of the results?
Yeah, you bet. Probably start easy here. What is CARTITUDE-4? What is the CARTITUDE platform? It's a platform that is investigating cilta-cel or Carvykti in patients with relapsed and refractory myeloma. We have CARTITUDE-1. It was presented in the last couple of years, and that's looking at Carvykti in patients with later line disease. And CARTITUDE-4 is a randomized phase 3 trial looking at Carvykti or cilta-cel in earlier lines of therapy, so less heavily pretreated patients. So this is a study design. You can see here patients were required to have 1 to 3 prior lines of therapy, including a proteasome inhibitor and immunomodulatory drug. All patients needed to be refractory to lenalidomide. And importantly, no patients could have a prior BCMA, B cell maturation antigen, or CAR T therapy. Over 400 patients were included here. Randomizations 1-to-1 to either standard of care, which was either PVD or pomalidomide, Velcade, dexamethasone, or DPD, which is daratumumab, pomalidomide, dexamethasone versus cilta-cel. So those patients treated with cilta-cel would receive either PVD or DPD as bridging therapy. The primary endpoint is progression-free survival, and the secondary outcomes you can see here included rates of complete response, rates of MRD negativity, sustained MRD negativity, quality of life, overall survival, and safety. The last point to make here that's highlighted on the slide is based upon these results, the CARTITUDE-4 results. Carvykti was FDA approved for patients with 1 prior line of therapy, including an IMiD or PI that are lenalidomide refractory. So this was the big news last spring in April.
So I think that this year we saw some updates at the IMS meeting. So can you tell us about what was updated? Seems like we have some more data on longer term outcomes.
Yeah, so the PFS this is a big deal. So the median follow-up at 33.6 months. You can see true separation of those curves. So the red curve you see here is the cilta-cel treated patients, and the black is a standard of care. You can see that there's about a 70% reduction in the risk of progression or death based upon that hazard ratio of 0.29. So what we're seeing is what we would expect, is that patients are doing remarkably well on the BCMA CAR T therapy.
And I guess they analyzed patients as per how many lines of prior therapy. They went a little deeper into it.
Yeah, I mean, the big question here is, okay, well, the median PFS from CARTITUDE-1 was close to 3 years, and it was a bit jaw-dropping when we saw those numbers. We're seeing those outcomes in our clinics, but to actually see the compiled data was outstanding. And so the next question is how is this going to behave when we treat in the earlier lines? And you can see here this PFS curve on the left side, looking at CARTITUDE-4 versus CARTITUDE-1, the as-treated population, that PFS was improved in the CARTITUDE-4 treated patients compared to those that with more heavily pretreated disease. And then when you look at the PFS curves based on prior lines of therapy and the intents to treat population on CARTITUDE-4, you can see that those patients that were treated with cilta-cel had improved outcomes in all comers over those treated with standard of care. And then when you separate out those patients that were treated with cilta-cel with 1 prior line of therapy versus those that were on the CARTITUDE-4 trial that were treated that had 2 to 3 prior lines of therapy, that those patients that were being treated with Carvykti earlier had improved PFS. So interesting data that points us to to this idea that if patients are lenalidomide refractory and have had one prior line of therapy, that cilta-cel is behaving very well in these patients.
And what about the depth of response and the duration of response?
Yeah, I thought this was really interesting data. So again, the median follow-up is 33.6 months. You can see that the overall response rate was about 85%. And when you look at the bar graph here on the left side, at a median follow-up of 16 months, the complete response rate or complete response or better rate was 73%. And was then 77% when we looked at later follow-up. But when you look at those patients that had stringent complete response, it was 58% and then 69% at later follow-up. And the idea here is that patients are responding, but patients are also deepening the response over time, which I think is really incredible. And then when you look at the table on the right, the duration of response at that median follow-up at 33.6 months, the median has not been reached in the cilta-cel treated patients and was about 19 months in the standard of care patients. So what I take from this is in those patients that are responding to the CAR T, patients are having long responses, and in some cases, those responses can deepen.
And obviously, one of the things that is often a question is about bridging therapy and what the goal of bridging should be in patients with myeloma headed to CAR T. So I understand there was an analysis trying to look at this issue.
Yeah, you bet. There's, the question that we ask ourselves in clinic is how much is too much disease to go into the CAR T? And I think that when we were looking at, the phase 1 trials, it was let's get these patients on treatment because these drugs appear to be so effective. And as we're getting a little bit further into the development of these drugs, it's becoming more clear that there's some nuances to, how can we improve the outcomes in our patients. So this particular analysis looked at CARTITUDE-4, but looked at two different populations. Those patients that were on bridging therapy that had 25% or greater reduction in the amount of tumor that they had from the time of leukapheresis to lymphodepleting chemotherapy versus those who either didn't have that degree of tumor reduction, had no change, or actually had increased amount of disease during that bridging period. And you can see here that those patients that had greater reduction of tumor during the bridging period had improved outcomes as measured by PFS. So, when we're thinking about our patients, we are seeing clinically that those patients who go into CAR with less disease not only are having better responses overall, but also seem to be getting through the CAR T without an increase in profound toxicities.
And what do we know about survival?
Well, CARTITUDE-4 is the first trial to show an overall survival benefit with the utilization of CAR. That's a big deal, and we see the separation of the OS curves here. So 30-month OS rates, 76% in cilta-cel treated patients, whereas 64% in standard of care patients. I think it's becoming clear that these are highly effective drugs, and patients are deriving a great amount of benefit from their use.
So obviously, one of the things is they are approved for second line and beyond. Carvykti is at least. So is this something that we should be offering to all patients? And I believe there's some data now starting to emerge. And if you could review with this, and then I will ask you where you are using it in your own practice in the second line. But looking at the data first, can you tell us about this abstract that was presented at IMS?
Yeah, I think that just to lay the foundation of this discussion, we know that cilta-cel and the CAR T therapies are associated with rarely, but we can see profound and potentially life-altering toxicities. And so the question is you take somebody who could have derive multiple years of benefit from, say, novel therapies without these risks of late onset neurotoxicity or these other types of issues? Or do you take them to CAR T as early as possible? We'll loop to what I'm actually doing, but I think this is a really neat analysis that was done on CARTITUDE-4. So, we have patients who were able to say, listen, they've got high risk disease, double, triple hit myeloma. But really, those patients who have functionally high risk disease are the ones that we worry most about. And this particular subgroup analysis identified or defined those patients as those that had disease progression 18 months or less after receiving auto or from the start of frontline therapy, a new diagnosis if they didn't get an auto transplant. So, how is cilta-cel behaving in those patients, all comers that had one prior line of therapy versus those who had one prior line of therapy but had functionally high risk disease? And you can see that the breakdown of the disease characteristics here. But if we go to the next slide, I think that's really where the power of this analysis is. So, looking at overall response rates, again, all comers versus those with functionally high risk disease, overall response rates were very similar. Those patients with or the rates of complete response or better, very similar. Rates of MRD negativity, very similar. Okay. Now we look at the Kaplan-Meier curves here. You have all comers on the left, and then you have those patients with functionally high risk disease and one prior line of therapy. And you can see that those curves in the cilta-cel treated patients are not too different. So the 12-month PFS rates in cilta-cel treated patients, all comers versus those with functionally high risk disease, about 77%. And that's at 12 months. So we're not quite sure what's going to be happening later on after the 12-month mark. But we know that within that first year that cilta-cel is really effective in this functionally high-risk patient population. And if you want, I can just jump into how I would interpret that
Yeah,
data in my own
we
clinic.
do.
I think that because of the risk, while rare, but risk of this motor and neurocognitive toxicity, the Parkinsonism that we see, potentially some gut-related toxicities as well. I mean, these are real toxicities, and so in my mind, and if I have a patient who's PI and IMiD refractory, PI and IMiD exposed, Len refractory, and they have high risk disease, whether it's functionally high risk disease or high risk disease measured by R2-ISS or double or triple hit disease, I am recommending that these patients all go to cilta-cel. I think it's the right move, right? These are patients who need the best therapies first. Now, it becomes much more of a conversation with those patients that don't have high-risk disease. And we talk about things like, okay, well, treatment-free interval. So these patients aren't currently getting maintenance therapy after CAR T. Some people think that that's highly appealing, right? And they will take the risk of some of those rare toxicities to have that period, that treatment-free period. So it's much more of a conversation in those patients that don't have high-risk disease, but in those patients with high-risk disease, I'm definitely trying to move them towards cilta-cel at first progression.
So you mentioned some of the toxicities you're concerned about. So let's just dive in a little bit. So what do you worry about? I guess CRS and neurotoxicity is one of the things that is common across CAR Ts. So what can you tell us about this product and anything unique?
Yeah, we can break this down, how the table is broken down. So cytokine release syndrome or CRS, 76% of patients have CRS, but you can see that the vast majority of those events are going to be grade 1 or grade 2. And what does that mean? Well, grade 1 CRS is a fever. Grade 2 CRS is a fever with need for oxygen or need for IV fluids. And so these are easily managed in the hospital and with some tocilizumab, steroids, whatever. But we don't worry so much about those CRS. We've got the experience with those toxicities. Now, the ICANS neurotoxicity, 20% of patients have some neurotoxicity. Most of these, again, are low grade. You can see that these are split out to ICANS, which is 4.5% versus other. And I think other, so ICANS is what we're seeing in this first couple of weeks of treatment, usually after the CRS, usually at the 10 to 12 day mark. But when you look at the other category, these are the later onset neurotoxicities that we are concerned about. So cranial nerve palsy, you can see the median time to onset is 21 days. Peripheral neuropathy, median onset's about 2 months. And then we have this motor and neurocognitive toxicity, and we're seeing that on average starting about the day 90 mark. And so cranial nerve palsy, peripheral neuropathy, we put some steroids on board, and for the most part, we're able to get those toxicities cooled off and reversed. We're not able to reverse the Parkinsonism in all patients. In some, for sure, but we have seen long-lasting toxicities in some of these patients. And I really think that, while it's more rare on the CARTITUDE-4 data set than it was in CARTITUDE-1, but these are real, and patients should be counseled about this.
So, do we know why these occur?
Well, we know that the CAR T is able to penetrate into the CNS, and so I think that the thought out there now is that this is really about that CAR T infiltration. That being said, when we give IT chemotherapy and clear CAR from the CSF, we're not seeing rapid reversal of these symptoms in all the patients. And so, I think that there's probably a more nuanced and more complex set of mechanisms involved with these toxicities, but certainly that the penetration of the CNS by the CAR T is something that's of concern.
So it seems like the cranial nerve palsies is where the conversation is now more focused on in earlier lines of treatment. Parkinson's certainly remains a concern, but as this slide suggests, it's not as common. So are these cranial nerve palsies, to your knowledge, reversible? Are these permanent?
Yeah, we've had a handful of patients develop cranial nerve palsies, and we've seen reversal of all of these palsies. So it's not fast. It can take some time, up to a couple of months, but we've utilized steroids effectively to reverse steroids in some patients to reverse these symptoms.
So, as far as then other late toxicities go, what else should we be aware of with CAR-Ts?
Yeah, infections are a big one. We believe that monitoring CD4 counts is an effective way at guiding our utilization, PJP prophylaxis. We're seeing a lot of viral infections, a lot of respiratory infections. So, being it's a BCMA targeted therapy, especially in those patients who have hypogammaglobulinemia, we're utilizing IVIG relatively aggressively in these patients. But one of the big things that we saw on bispecific and CAR trials, they were being run during COVID, and so COVID was a real problem at that time. We've got a better handle on COVID, so we're not seeing some of those COVID-related toxicities now, but certainly the lung events are something we need to be thinking about. So adequate prophylaxis is very important in these patients, and ongoing monitoring and early intervention for any infections that may arise. The other thing we're thinking about is the prolonged cytopenias. We've shown a couple of publications are out there now. We're included in one of them, looking at stem cell boosts for patients who have prolonged cytopenias. Generally, we'll think about that after the day 30 mark. We need to give patients some opportunity to recover their marrow function before thinking about pulling stem cells out of the freezer. But that's certainly something that we need to be thinking about. And obviously, patients will be at higher risk for things like fatigue and infections, and very rarely bleeding with the prolonged cytopenias.
And you mentioned that this was done in the era of COVID. So there were, I guess, some deaths also due to infectious causes. Can you give us a little idea of that, and what other things are we concerned about? I hear that secondary malignancies is also another area of conversation.
Absolutely. So, because you put a box around it, we'll highlight the fact that the percentage of deaths on the cell-to-cell arm were less than what we saw in standard of care. I think going down to the treatment emergent adverse events, you can see that there was 4.8% in the cilta-cel treated patients, 2.4% in those patients who received standard of care. But when you look more closely at these events, we think that those COVID pneumonias were really driving that difference. So, we know that there are deaths related to infections, but I think that you remove the COVID-19 aspect of this, and I think that it levels the playing field between the cilta-cel and the standard of care. And then the issue with second primary malignancies is a very complex one. We have patients who have underlying malignancy. They've received therapy, potentially up to 3 lines in this cohort. And that usually includes a transplant, right? So they've been exposed to alkylators and heavy chemotherapy, and then we come in and we give them lymphodepleting chemotherapy on top of that. So, I think that the question is always are these second malignancies related directly to treatment, indirectly related to treatment and associated with their disease course, or is this patients have had these underlying problems that we're just seeing come through in time. And I think it's probably a combination of all of those. One of the malignancies of interest is T-cell malignancies, and there's a big analysis done. I can't remember the exact numbers, but when you look at the rate of T-cell malignancies in the patients who have been treated with CAR T, it matches the rate of those malignancies in a more general population. So, I think that longer term follow up will have a better idea as to whether that the CARs are directly associated with second primary malignancies.
So one of the questions is obviously sequencing of our conventional therapies with CAR Ts now that they have moved into earlier lines of treatment. And you mentioned where you yourself use cilta-cel in second line, but by and large, I guess we are still trying to figure out what is the best sequence for some of these patients other than high risk. And I understand there was this analysis that was attempted at the IMS meeting again to see what would be the best sequence. What was it that this analysis tried to do, and what were the results?
Yeah, this is an interesting question, isn't it? This idea of sequencing with our standard of care drugs, and the increasing complexity of this question once the bispecifics come into earlier lines of therapy. So, I think it's important that we're trying to utilize all the resources that we have to try to answer the question of when do we use these drugs and how do we use them the right way. And so, Dr. Fonseca presented this down in Rio. The idea here is you take the data from CARTITUDE-4 and real-world data from the Flatiron Health Myeloma database. You take a look at patients who are receiving both standard of care and cilta-cel at second line, and then those that are receiving the CAR or standard of care at later lines. And then you do some modeling. And you show the next slide. And you'll see that based upon this modeling, the overall survival at 5, 10, and 15 years favors the utilization of cilta-cel before standard of care. And I think that at the end of the day, this matches up with what we do in general in myeloma, which is we use our best drugs first. And this is a question that came up with utilization of daratumumab in the first line setting. Well, do we use dara in a quad or not? And the idea there is, yes, we use the best drugs first. And so I think that, once we're able to figure out management of some of these later onset toxicities and the performance of the CARs, that I think that earlier utilization of the CAR is going to be a standard of care approach for most patients.
So I really wish to thank you very much for giving us that update from the IMS meeting. We have the American Society Hematology meeting of 2024 coming up in just under a month, and I'm sure there'll be more to learn there. And I hope I can have you back to tell us about findings from that and other meetings in the future.
It's been a pleasure, and I'd be happy to come back whenever you call.
Thank you very much. I look
Thank you.
forward to talking to you again.